Hi, I'm Chris Stroud, a board-certified obstetrician-gynecologist of more than 30 years. I'm the founder and the president of the Fertility and Midwifery Care Center in Fort Wayne, Indiana. I performed thousands of laparoscopic procedures, both traditional and robotic, related to pelvic pain, endometriosis, and infertility. And my goal here is to share with you some of my experience using the ForTec Medical Aurora CO2 laser as a tool in treating disease related to endometriosis. I think most viewers have heard commonly that 1 in 10 women are affected by endometriosis. Personally, I think that number is very, very low. It's a universal challenge that doesn't discriminate based on age or ethnicity or socioeconomic status or really anything else, and it has the potential to impact women across every stage of their reproductive life, from schoolgirls missing soccer practice to perimenopausal and postmenopausal women with debilitating pain. Endometriosis can significantly affect a person's quality of life. Now, despite its prevalence, endometriosis often goes undiagnosed or misdiagnosed, leading to delays in appropriate diagnosis and management. I would argue that far too many women endure years of suffering and numerous doctor visits before receiving a proper diagnosis, with an average diagnostic delay, it's been said, ranging from 7 to 10 years. The only reliable, reproducible method for diagnosing endometriosis is diagnostic laparoscopy. Who should undergo laparoscopy for the diagnosis? Anyone with significant dysmenorrhea, pelvic pain, mid-cycle pain, or pain associated with bowel movements around menses, and most certainly anyone with infertility and the absence of a known explanation. Numerous studies support that excisional surgery, that is, the complete removal of the lesions, offers the best opportunity for both pain relief and fertility preservation and enhancement. The CO2 laser offers the ability to do this really in a safe, controlled way with minimal, if any, damage to surrounding tissues. And the skills necessary to accomplish this robotically are particularly easy, I would say, for those surgeons especially that are already performing robotic procedures. So I'm going to start with a series of videos and sort of walk you through them, pointing out some of the roles and the uses of the CO2 laser. Now, in this first case, what I would like to show here is the excision of adhesions, commonly known as lysis of adhesions. I like to say excision of adhesions. They should be completely excised, not just lysed. Because if you send that tissue to the pathologist, depending on your relationship with your pathologist and their willingness to look, they'll find endometriotic lesions and tissue in those adhesions. So you can see here, I'm using the CO2 laser as a cutting device. This is a power setting of typically 4 to 6 watts, depending on the location. If you've ever tried to excise adhesions like this using shears and didn't use cautery, you probably remember that there's a lot of bleeding. But you see here there's really no bleeding. So the CO2 laser has that ability to both cut and coagulate simultaneously. But it's excellent in this role. There's really minimal, if any, surrounding tissue involvement. It does take some practice to learn to position the tissue, as you can see I'm doing here with my left hand, such that you're cutting in just the plane that you want to be in. But with really just a little bit of practice, the skills develop very, very quickly. If you are not in the habit of excising adhesions like this, I would encourage you to begin thinking like that. As I said, these will invariably contain endometriotic tissue, and so to leave these adhesions behind is leaving endometriosis behind, and that's going to negatively impact the woman's opportunity for pain relief, increase her recurrence rate, and not help with her fertility enhancement and preservation. So again, you can see here that it cuts really very, very nicely. There's really no sort of past pointing, or if there is, it's very, very minimal, and particularly at these low power settings of 4 to 6 watts. The power setting that you use and the distance from the tissue, it's really hard to describe in a protocol sort of way. It's something that you'll just have to experiment with, but it very quickly becomes second nature. Here I'm lysing really right on the surface of the bowel, and you can see there's no involvement of the surrounding tissue whatsoever. Again, not difficult to develop that skill with just a little bit of practice and time. This can be done with traditional laparoscopy. I prefer not to do it with traditional laparoscopy. My preference is robotic by far, but it certainly can be done. The device is just a little bit different, and obviously you don't have the same mobility, but with some practice it can be done with traditional laparoscopy. Here I want to show that I'm removing a large endometriotic lesion and tissue that is right over the right ureter. And what I want to show here is that with some time and some practice, you can dissect right on the surface of sensitive tissues like the ureter with no lateral spread or involvement of the laser. Now, I don't recommend that you go doing ureterolysis like this on your first procedure. But again, with a little bit of time, with a little bit of practice, this becomes very, very easy to do with confidence and safety. You'll also see a couple of times just like that, where I like to use the back side of the conduit as a blunt dissecting tool. You want to be careful not to actually touch tissue with the fiber itself. You can see the fiber extending beyond the end there just a little bit. Touching tissue with that fiber invariably will damage that fiber, and you'll have to replace it in the middle of your case. But using the back side of that conduit as a blunt dissecting tool works very, very nicely. But I think you can see there that it's an excellent cutting tool. This is at 4 watts. I may alternate between 4 and 6, depending on the thickness of the tissue and the distance that I am from it. I'm a bit closer to the tissue here, I think, than I was in some of the adhesion lysis there. As you get closer, it becomes more of a cutting tool and less of a coagulation tool. And again, I'm comfortable working right adjacent and on top of the ureter, just based on practice and experience with how that beam behaves and how the tissue behaves around it. And that comes very quickly with really minimal practice and time. So that's a great example of excising a lesion, and particularly in this case, in a sensitive area. The next thing I'm going to show there is in the distance you see what we often call pseudo defects. I know those have varying terms, but I think that's one of the more common ones. And there's endometriosis in the base of these defects invariably. If you look hard enough, you'll find endometriosis in the base of these lesions. And to be effective, you need to excise that entire defect or sort of pseudo sac there. And this does a great job of displaying how that's accomplished. I'm very close to the tissue here, and it gives me the best cutting behavior when it's that close. And this is a power setting of 6 watts for reference. I think this does a great job of demonstrating when the tissue is on a fair amount of traction, counter-traction, you get really beautiful separation of the planes with the laser, more so than really any technology that I'm aware of. It's a very satisfying dissection. Going to fast forward that to the next section. I guess maybe I'll show off my, my excision there just a little bit before I move on to the next section. So here I'm demonstrating laser of endometriotic adhesions on the surface of the colon. This is at 4 watts, and you can see that I'm several centimeters away from the target tissue. And then I'll start far, and then I'll come in a little more near, watching carefully how the tissue responds to the laser. Again, I don't recommend lasering on the surface of the colon as your first experience, but with very little time and a little practice, you will quickly develop a sense of how the laser behaves with the tissue so that you can confidently laser on delicate tissues like this. But it does a tremendous job at vaporizing that tissue. This is probably a good time to point out as well that this is not cauterization. There's change in the tissue color there that many patients, when they watch our surgery videos, will think that we're cauterizing the tissue. It is not cautery. Now, I for a moment, wouldn't suggest that I'm an expert in the physics of CO2 laser technology, but the tissue actually becomes water fiber. It completely vaporizes. What you see escaping there is not smoke, but it's vapor. And so vaporizing the tissue like I'm doing here on the surface of the colon is the same as cutting or excising and removing that tissue. It is no more. And you can see it sort of bubble up and really just disappear. We'll see that again in just a minute on some peritoneal lesions. But here what I really wanted to demonstrate most is that it's really quite simple to laser on the surface of the bowel with confidence that you're not going to injure the bowel. Once you get a sense of depth and depth involvement, certainly I use typically 4 watts in this setting, occasionally 6 watts. But that's something that comes with practice and just personal preference. But very quickly, you develop a sense of how which tissues will behave at which wattages and which distances from the tissue. On the ovary, for example, I typically use 10 to 12 watts, and I operate rather close to the ovary. On the colon, I don't want any depth at all. I want to start very shallow and then gently increase my depth. I'll always start with 4 watts on the surface of the bowel like this. Here I'm just showing, actually indirectly showing a technique that I like here of suspending the ovary to get the fallopian tube out of the operative field. I'm using here just a 4-0 V-lock suture, which is a temporary, as you know, suture. It's going to disintegrate and that ovary is going to fall back into its normal anatomic position. But I don't want it there to be in the operative field now while I'm operating, but also in those weeks right after surgery while the peritoneal tissues are healing. I don't want the tube to be involved. And so I'll suspend it up to the ipsilateral round ligament. That works very nicely, and it's easily accomplished with a 4-0 V-lock. Some of you may prefer Stratafix. I'm not advocating for one company over the other. I prefer the V-lock suture on the ovary in particular. I certainly use their competitor Stratafix on fascia and some other tissues, but I particularly like the V-lock and the way that it interacts with the ovary. I'm going to fast forward that just a little. I think you get a sense of how that works. These are pretty classic inflammatory yet superficial lesions on the surface of the ovary. This is at 10 watts, as I mentioned earlier, and I'm relatively close to the tissue there. But this is a cystic ovary, and you can see that even at 10 watts, I'm not getting low enough in the tissue to involve the cyst itself. I'm back down to 8 watts on this tissue, and if you look closely, you can see that the peritoneal tissue is actually disappearing. It's disintegrating. You can see a little bit of the steam there as the tissue becomes water vapor. But superficial lesions like that really respond well to a low wattage and relatively larger distances or greater distances from the tissues. You can see that I'm doing there. And the tissue vaporizes, disappears really quite nicely. On this darker, more nodular, classic-appearing lesion, you'll see that I'm going to hold the laser in one spot and penetrate much deeper into the tissue. And I want to make certain that I'm removing all of that endometriotic tissue, and those nodular lesions can be significantly deeper than the superficial ones, so you want to make sure that you've penetrated deeply enough to remove that tissue. I typically increase to 10 watts for these more nodular lesions when I'm vaporizing them. Again, this is another example of superficial ovarian surface involvement. And this is 10 watts, and I'm just completely vaporizing those superficial lesions. I don't know of a better way to treat these ovarian surface lesions than CO2 vaporization. Cautery is just that. It's cautery. It causes a lot of surrounding tissue damage, and the risk of adhesion formation after cautery is very, very high, whereas it's not with laser vaporization. This is, in my opinion, really the only way to treat these types of lesions. I really like this example of widespread, as you can see, peritoneal hemosiderin stained lesions. If you excise those and send them to the pathologist, again, depending on your relationship with your pathologist and how compulsive they want to be, they will invariably find classic endometriotic findings in those lesions. This is a power setting of 10 watts with a fair amount of distance to the tissue. But this is the perfect way to treat these superficial peritoneal lesions. By far, I think the most superior way to do this. Otherwise, it would require a complete peritoneal excision, whereas it's much more quickly and efficiently treated, in this case with the laser. At 10 watts, you can see how much tissue sort of vaporization happens on this thin peritoneal tissue. But this is a terrific way to treat these lesions, and especially when they're widespread, in this particular case, really all over the peritoneal surfaces. You can accomplish complete treatment here in a fraction of the time if you tried to excise every one of these lesions. Here I'm just showing it down around the sacral promontory, pushing the colon to the side. And I think I'm demonstrating here that you can be very comfortable, again, at low power settings. I'm at 4 to 6 watts here, lasering really very close to the common iliac artery and vein there without worry of inadvertent deep penetration of the tissue. That takes only a little bit of practice and a little bit of time to develop that confidence. I'm not trying to show complete treatment of all the pathology in view here. I just sampled this for our purposes. This has nothing to do with the laser. It's just a plug for what we often call pelvioplasty. These are areas where I've used the laser to excise large nodular endometriotic lesions. And instead of leaving those open and inviting adhesion formation as it reperitonalizes, I prefer to close those. This is a 3-0 V-lock suture, and I'm going to close those and try to imbricate the edges to the degree possible in an effort to prevent adhesion formation, particularly with the fallopian tube so nearby. Very simple to do robotically. Doesn't take a lot of skill, just a little bit of practice. Really, all it takes is a willingness to do it. It's going to add some surgical time. After a few cases, you get very, very efficient at this, but it does take a little bit of time. The beauty, of course, of the V-lock is it doesn't require knot tying, and it holds very, very well, and it's a delayed absorbable suture. As I referenced earlier, Stratafix would work fine here. I prefer the V-lock for ovary, but for peritoneal tissue, I think V-lock and Stratafix are relatively equivalent. I think you'll get a sense here pretty quickly that you can completely reperitonalize those areas. I'll fast forward just a little bit to the final product, and you can see those come together really nicely. There's no raw edges exposed, remarkably and dramatically, I should say, decreasing the opportunity for tube and other involvement. You can see there that I'm not sewing edge to edge. but I'm trying to imbricate, much like many people would imbricate a uterine incision, in an effort to bury and hide that raw peritoneal edge. Not difficult to do, takes a little bit of time. You do get very efficient at it relatively quickly, but it leaves the pelvis in a much better position and a much healthier position than leaving all of that tissue exposed. Well, I know this has been brief, but I hope you found the information helpful. I hope maybe that I've changed your perspective on endometriosis in general, and certainly that maybe I've changed the way you look at the CO2 laser as a tool in the treatment of this very common disease. If you'd like to learn more about the use of the Aurora laser, contact your product representative, and I'd be happy to help you really in any way that I can. Thanks for joining me, and I look forward to joining you again soon.